Okay, so let's just review the applications of our traction before you are sent on your way to work on your competencies. So the patient position is important. Cervical, we can either do sitting or supine. Um, Almost always recommend supine. There are some mechanical traction that go kind of over the door or something like that where you do more of a seated, but ideally we want to use supine unless that's too painful for the individual. In lumbar, based on the type of scenario that we have, there's some auto or positional traction that's done in standing, there's sitting, there's supine, there's prone, there's going horizontal, there's going inclined. It just kind of depends on the type of traction that you're doing. So one of the best things to do is find out what position decreases their pain in real life, and try to mimic that within your traction. You do want to make sure that you get muscle relaxation. So if they're in a position where they're guarding, that's not going to help them produce the traction. And so you want to get in that position that's most comfortable for them where we get that muscle relaxation. As far as the mode, we can do the sustained or the intermittent. Usually disc protrusions, again, potentially like more of that intermittent according to research. Other research shows that they maybe like more sustained. Facet issues, facet joint pathologies seem to like more of our sustained. Degenerative disc disease or joint hypermobility, again, we'd ideally not use it for hypermobility. Um, but again, if it's more hypomobile joint, then maybe intermittent short hold rest periods might be beneficial. There's the charts in your book, and in our notes to look at the pathology and determine what works. But also try things, see what helps your patient most, and see what can be done. Durations can be a few minutes up to maybe 40 if you have a mechanical machine. For the most part, we tend to do shorter, especially in the beginning times, and we usually almost start with manual in the beginnings. Also thinking inversion table, we're not going to have someone hanging on an inversion table for 40 minutes. And usually we do more of an intermittent with that if you're going to try to do a longer sensation. As far as the force, again, we have to overcome that frictional force of the body, and that's typically over half the body weight, especially for lumbar spine. So we have to overcome that resistance to the muscles and the soft tissue, and produce the traction. So with the cervical spine, we need a minimum of about 24 or 25 pounds of cervical traction. We also have to think about the angle of pull. So again, the neck flex to about 20 to 30 degrees, especially gets you the lower cervical vertebrae. Also usually opens up the spaces for the intervertebral foramen a little bit more. If it's more of a facet, we can be more at about 15 degrees of flexion. Again, if that position also creates less pain in their real life, that's also a sign that that's a position that we potentially want to use within traction. For lumbar, we start at about 25% body weight, and if that's easily tolerated, we go up to 50. Again, that's much easier to determine when we're using a mechanical traction where we can set those forces. We potentially, as manual, have to kind of just go with as much as we can produce. A good kind of indication is if we've eliminated the lumbar lordosis, the lordotic curve in the spine, that's usually a sign you've gotten to that 50% of the body weight. Again, angle of pull can also potentially affect that. So if you put them into a little bit more extension or a little bit more flexion, or if we go side bending, that can also affect some of that. As far as frequency, there's no real scientific backup for any stipulation as far as frequency. Some people say that it should be done every day. Some people say every other day. If it's something that they can do at home, they should do it multiple times a day. It's all kind of anecdotal. There's not a lot of research on that. The one thing we do know is that insurances tend to pay for traction only every other day or every couple days. So you usually can't get daily traction and bill for that with insurance. So again, just to review our applications, so the effects we're going for, again, some of these would be, again, then into our indications. So we'd want to gain these effects in order to affect the conditions that the individual has. So the advantages of using traction is that we can do some of these effects that we haven't been able to really do with any of our other modalities so far. Disadvantages, manual traction is hard for the clinician. It's tiring, it's time consuming. To do mechanical, you have to have special equipment, and really all these effects that we get are very short-lived. They reverse very quickly, and so it's something that we have to always combine with something else. So these are the conditions that we would potentially use traction for. So again, finding those in our patient, having a good diagnosis of what's going on is really important for traction to be indicated and for us to want to use it. So you need a really thorough eval. You also ideally want to get x-rays before you do any traction, because we want to make sure that there's no fracture in the area. We can usually then also combine traction, heat, massage, exercise, potentially maybe immobilization if they have other issues that they're going for. E-stim can help with some of the pain, things like that. So our contraindications, again, are kind of general contraindications. Biggest one is if we don't have a good diagnosis and if we don't know if they have fractures, any acute, basically any hypermobility. Again, lumbar, we want to be concerned about hernias and pregnancy and peptic ulcers. Our inversion table, we want to be concerned about glaucoma and high blood pressure, so things like that. Precautions, again, don't substitute this for exercise. We want to monitor them, want to make sure that their symptoms don't increase, and make sure that we have a good diagnosis. Pre-application steps, evaluate, set your goals, check your contraindications, prepare the patient psychologically. So you'd also want to do your patient-oriented outcome here, right? Get a before number. Explain the procedure and kind of that pulling cessation that they should expect. It shouldn't produce any pain and should actually relieve their pain and their symptoms. That's really important. It's hard to demonstrate on yourself, but maybe the mechanical would be one that you'd want to demonstrate so that, you're strapping people's head into things or their body. Sometimes they might want to see that in action before they actually do it. Check all of the precautions that you have. Prepare the patient physically, make sure they're comfortable, remove anything that's going to be in the way. So, if clothing is inhibiting your grasp or the straps, we might want to remove that. When we're doing manual, we need space to do these things. So make sure stools are out of the way, that everything's proper. Position the patient, prepare the equipment, put the straps on, set your treatment, set your forces, set your duty cycles. Make sure that, again, the patient is comfortable, that the straps aren't hurting them, or that your hand placement isn't hurting them. If you're doing manual, trust is a big thing too. You're going to be, especially with cervical, you're holding their head. So gain that trust for them. Let them relax into that position before you start. When we position our patient too, again, thinking about that you want to cradle the head. We might want to flex the head to open that up maybe 20 to 30 degrees. Again, making sure with the lumbar, if we're doing the leg pulls, that we're in the right position. That unilateral leg pull has, that 30 degrees of abduction, a little bit of hip flexion, about 30 degrees of hip flexion, and maximum external rotation of the hip. And then, again, on the tables, making sure that you set the tables appropriate for the individual. Then our application, right? Cervical manual, it's a gentle pull. You can do intermittent or sustained, though it's very hard to do sustained. You'll be tired. So we usually do intermittent treatments. Cervical for mechanical, we can do intermittent or we can do sustained. 3-to-1 ratios, 30 seconds on, 10 seconds off, 40 seconds on, 10 seconds off, something like that. Lumbar for manual, we want to steady pull until we get that distraction. We might have to strap them down, worry about the friction on the table. You need to kind of think about those things with the manual traction. Mechanical traction, again, we can set up intermittent or sustained. We can set our forces, set our duty cycles, set our treatment times, things like that. Dosage, typically cervical is 20 to 25 pounds of force. Lumbar, we start with about 25% body weight and progress to 50%. Length of the application, if we're doing sustained in the cervical, 3 to 10 minutes. Intermittent, 20 seconds on, 5 seconds off, or 3 seconds on, 10 seconds off. It just kind of depends. Lumbar sustained, 4 minutes plus. Some people will lay on that table for 40 minutes. Intermittent, 15 seconds on, 10 seconds off, 30 on, 10 seconds off, somewhere in there. Maybe about 20 to 15 minutes of treatment. It just kind of depends. Frequency, you can do it every day. Again, research doesn't really show benefits one way or the other. Duration, as long as it's needed. As long as we're gaining points on our patient-oriented outcomes, right? As long as they're getting better, we should continue to use it and always implement it with other modalities, specifically usually exercise. Post-application steps, gently ease them off. You don't want to just stop the tension. So ease them back. If you're supporting them, if it's manual, you want to make sure that they know that, you're not going to hold on to their head anymore. Undo the straps or the harnesses, clean up the table, do your patient-oriented outcome again, check their status, give them home instructions, any self or home treatments, start their exercises right then. Again, if you need to have them lie in a prone position for a while to gain some of that extension, especially for the disc protrusions in the lumbar spine, that might be something you need to do right then. Schedule your next treatment, tell them what their level of participation is, document, and then maintenance is really just keeping everything in working order. So lubricating what you need to lubricate, make sure the cords work properly, make sure things are calibrated.